Hello, everyone. Welcome back to the Rhythmic Sangani podcast. Here, we interview professionals in medicine, health, and science, and we discuss innovations that can aid in human longevity. Today, my guest is a plastic surgery physician's assistant. She practices right here in Pittsburgh, Pennsylvania at the Skin Center. Please welcome my friend, Shannon Masterson. What's up?
Hi. Well, thank you so much for having me. I'm so excited to be here today to talk about all things aesthetic and plastic surgery and PA. So thank you again so much for hosting me on the podcast today.
Yeah, I was really excited to have you on. And so, you know what's funny is that, because Instagram kind of shows like your mutual friends. You and I actually have like a ton of mutual friends, but we never like met up until like this point, and like we were never introduced to each other formally until very recently. And we didn't even meet in person until fairly recently. So it's just like, one, this city is just like freaking small, but also kind of big at the same time. And then also two, how I knew you was actually just through reputation, because I knew like you were just a kick-ass plastic surgery assistant. And then I also saw your educational content online that I really piqued my interest. It was really insightful.
Well, thank you. I mean, I think that the goal, with social media, especially, nowadays with, there's so much that you can do with it, but it's really nice to have some educational stuff out there. So I'm glad that Instagram exists for that reason. But yeah, it was so fun meeting you actually in person at our friend DC's Strike Studios.
Yeah. First of all, shout out to DC, Devin. He had his art gallery with Strike Studios. I recommend any of you guys check out his content and any of his events. It was just really cool to see. Like, he's a really creative mind. So if you guys like ever go to any of his events, you won't be disappointed. But funny story for the audience though. So there I was like at the party. I was talking to a very handsome gentleman who, unbeknownst to me, was your boyfriend. And I was talking to this man, and I'm like, "There's no way this guy's here by himself." Like, we struggled to believe that. So I asked him. I was like, "Hey man, like, are you here by yourself? Like, who are you with?" And he's like, "Oh, I'm with my girlfriend, Shannon." And I'm just like, in my head, I'm like, "No."
Yeah.
And I turn around, and then it's you, another mutual friend of ours, and it was my date. And then you're like, I'm like, "Shannon?"
Yeah. We're like, wait a second. And the world just got smaller. I'm like, I'm going to see you next week.
Yeah, exactly. And I was like, well, what do you know?
I mean, that's Pittsburgh for you. And I mean, like I said earlier, I'm a Pittsburgh native, and still use Nav to get everywhere, but
I've been in the city. Like, I something we were talking as we kind of got here. Like, I've been in the city since 2018 for undergrad, and I still use Waze to get around. I know the pathways that I need to know, like at the back of my hand, but then other than that, like I use Waze.
Waze is just ideal for making sure that you don't get a speeding ticket.
That is true, but then I had a friend who was my driving instructor was a police officer, and he was like, the cops use Waze too, and I'm like,
Oh.
Okay.
Okay. It's like the schools who know that we're using ChatGPT.
Exactly.
Dun dun dun.
Exactly. But all right, so circling back to the main combo. All right. Plastic surgery physician's assistant.
Yes. So, I mean, I feel like I've actually maybe even outgrown the plastic surgery part because I haven't actually been in plastic surgery for the past 3 years. But it's definitely a part of my history that I absolutely love. I think that it's prepared me for being in the field that I'm in now. It's made me a much better provider in aesthetic medicine now, just having done all of the things in the face and in the body and learning to care for patients first. But yeah, it's been a ride. I absolutely love the field, and there have been its ups and its downs, but I've really settled into a really cool spot to, have other people talking about, oh yeah, that's that Botox girl. Just in saunas over at Mind Fuel Method.
Is that what they were? Is that your nickname, the Botox girl?
I don't know. I've heard a couple of iterations of things, and I'm like, all right, yep. I'm just over here slinging Botox and refreshing faces, I guess.
Oh my god, that's funny. I definitely want to talk to you about your plastic surgery experience. But before we do, just so we can break down some terms. So for the audience that may not know, what is a PA?
So physician assistant, or, the name is kind of being argued over as physician associate because they want to get away from thinking that we just, make doctor's appointments for the doctors or something.
You guys do much more than that.
Yeah. So physician assistant is a mid-level kind of career that so in medicine, it's going to bridge the gap between doctors and, access to healthcare, because we've all kind of been in the situation where you can't really get into the dermatologist for 6 months, but hey, who's this other provider here who can see me maybe in the next 2 or 3 weeks? Cool, I can get in with so-and-so. And, it's just this shorter medical model training. So it's similar training to what doctors experience, MDs and DOs, where it's a medical model, but it's just condensed. So maybe it's not as deep diving as a traditional medical route that doctors experience, but it's rapid fire and prepares you to clinically diagnose, treat, prescribe, and manage, and come up with treatment plans, obviously in the, within the scope of and discretion of a supervising physician. That's for physician assistants.
And you say not deep and in depth as an MD/DO, but even then, you guys know quite a lot. Like how much schooling do you guys have to go through for that?
That's a great question. And actually it kind of differs for some people who might know their readiness for becoming physician assistant. So traditionally it's a 4-year undergraduate, and usually that's in some sort of health science application. And then you go on after some more prerequisite hours and, clinical experience that they want you to have before going into PA school, just to make sure that this is what you want to do.
Right.
So applicants, beef up their resume and have all this clinical experience. At any rate, 4 years undergrad, and then it's usually a 2 to 3 year program as a graduate master's level. And it's split up, and we'll go into that. But the other model for it would be like a 5-year fast track program, and that's actually what I experienced.
So you did 5 years.
In total. So instead of the 4+2, I did 5 years in total because I knew that I wanted to do this in high school.
Oh, okay. So you knew from the get-go.
Yeah.
Okay.
I did.
We'll definitely dive into that later. But so for doctors, I know that the years are comprised of like a lecture for 2 years basically, and then you have your your remaining 2 years of medical school is a clinical, like you're going your clinical rotations. Is that a similar breakdown that you guys have for PAs?
That's exactly about half.
Oh,
so
okay.
We do our first half, the didactic in the classroom portion. So, covering lots of rapid fire, they always refer to it as like drinking from a fire hydrant.
Yeah.
And then you get into the clinical part where you go out to different rotations, and there's a whole list of different rotations that you go through. But traditionally as a PA, it was around a 6-week rotation. You did 8 or 9 different sites.
Okay.
And so, they call it a 2-year, but you forfeit your summers. It's not like school where you get a summer break. It's just the whole thing through.
I'm curious, like how, because you were probably studying like 24/7. Like I'm sure those years
eat, sleep, breathe.
Yeah. Okay.
All of it.
Yeah. Funny actually you say about the fire hydrant thing. So I heard another analogy for it that I thought was really interesting. They say medical school, but I think this could also be applied to PA school, is like having 10 pancakes to eat every day. And if you don't finish the 10 pancakes from the previous day, it just rolls over into the next.
You have 20 pancakes the next day.
Yeah, 20 pancakes the next day, and then it becomes 40. It becomes, if you're just not on top of your stuff.
Oh my gosh. And earlier on in school, I mean, because it was a 5-year fast track program, some of the things kind of even got pushed.
So you got more condensed than
Yeah.
Okay.
So it turned the temperature up even a little bit more. And earlier on, I was, I'm like, okay, this is college. This is how this is going to go. And then I was like, oh no, I need to change my studying habits immediatly. So that became pretty apparent definitely by my sophomore year.
Yeah, it's something I had to experience for the MCAT, just like studying habits, and something I'm going to have to experience for when I go into medical school, and having to adjust to that faster pace. So you were talking about the different clinical rotations you guys have. So what were the different rotations that you guys were able to experience at PA school?
Yeah. So definitely family medicine and internal medicine. So, generally they want PAs to be able to go out and practice in family medicine and really help to bridge that gap, and improve access to care. But But then they also expose you to surgery. And I mean, that's what I really liked. ER. I loved ER. I actually picked, yeah, I loved ER. I thought that I had a job lined up in the ER after school. But thank goodness things didn't happen the way that they happened. I'm so happy where I am now. But ER, that was one of my elective rotations because I really thought that that's what I was going to do. There was a research I did. What was it? Oh, that was like an endocrine rotation, pediatrics, OB-GYN. So you'll get a little taste of everything.
Okay.
And I always told any like students who were going through PA school, I'm like, it's such an amazing opportunity after you just absorbed all of this knowledge from the classroom. And then you go out there and you realize you don't know anything and how anything gets applied, but it's kind of in your head and you're like, oh yeah, knee-jerk response. When I see that, we do that. But anyways, when you're out on rotations, that's a cool connect. But the even cooler part is understanding where you're lining up and where your passion is kind of resting within those clinical rotations. You know, where do you see yourself wanting to work? Where do you see yourself wanting to operate? Is it in a hospital? Is it in a clinic? Is it in a private practice? And largely my advice to younger PAs was pick your rotations wisely. And, you know, obviously programs don't let you reach out to clinical sites because they have to maintain, you know, a professionalism with them. But it matters so heavily what you expose yourself to.
Because I'm sure that you you tell me actually, your ER rotation, the positive experience you had with that probably had to do with the people you're working with there too. Right. So I know that preceptors can also shape the experience that you have at a clinical site. So then maybe you had like a negative impact with a negative experience with a preceptor. It might have shaped your experience with the ER differently. And you have a different recollection of that.
Absolutely. I had my first ER rotation up in Buffalo and I loved my preceptor. Shout out to Jackie. I know we're still friends on social media. So, but yeah, Jackie was amazing. She just like molded my mind about, you know, and I really respected how she carried herself as a physician assistant, you know, how she managed her patients. And I was like, wow, I really see myself wanting to do something like that and making an impact for her patients. And I saw that. I've always been very hands-on and it just made sense. Least favorite rotations were ones where, you know, you're just kind of used as like a glorified scribe.
And that's not what you guys are.
No.
Which is a shame that that's the case, because I think that's an underutilization of your guys' skill set.
Absolutely. And, you know, it's a beautiful thing when you have this level of autonomy as a provider and you can, you know, interact with patients like you wanted to. You know, you don't go into being a mid-level provider like a PA or NP, and you certainly don't go into being a doctor just to follow someone around on their coattails and say, okay, what are we going to do next?
That is a lot of medicine. That's a lot of medicine, though.
Yeah. So, I mean, you don't necessarily, charting, you can't get away from it. You have to do that. You're going to be your own scribe all day, every day, you know, unless you get some amazing dictation, or you do get a scribe, and great for you.
Or you just get ChatGPT.
Or, oh my gosh. Well, I mean, honestly, the AI that's coming out, I hate charting. I love interacting with people so much.
Well, that's why we got it. That's why part of the reason why I'm trying to become a doctor is because I want to have that relationship with patients.
Right.
Charting is just like a necessary
evil.
Not evil. Evil. Yeah. You know, it's part of the job that it's just one of the things that you're just not going to like. Yeah.
It's just one of those things I just like have to habit stack, you know, where I'm like, I have to do this and then I'm going to give myself a reward with a ton of chocolate. Because honestly, I thank myself later when I have like really amazing detailed notes. And I've always just been such a sucker for having such detailed notes.
Okay.
That, oh my gosh, yeah. That then in the future, it enhances patient care so much. So while I don't love it, I always thank myself later for it. So anyways, side note on charting.
No, it's okay. I love tangents. And but looping back. So, you know, we discussed the clinical sites you guys go into, but then what are the actual specialties that you can do? So
you will find PAs kind of a little bit of anywhere. So it could be something like family medicine, internal medicine, not as commonly in like OB-GYN, still there, but that seems to be more of like a nurse practitioner dominated route. You won't find PAs really traditionally in anesthesia. or anything like really lab based, like pathology. You're just
They have a pathologist. They actually have a specific role for that one. Actually, that's pathology assistants.
Exactly. So they're assistants and technicians, that really go into those.
Yeah.
But you won't really find PAs there. Technically, if you had a supervising physician in any arena, you can do it. It's just about a legal document saying, yes, this is an extension of the care, and this is what you work out. So it makes sense in any specialty, but generally what you do see is like a lot of surgical fields, family medicine, and I think
plastic surgery.
Yeah, plastic surgery. That was just dumb luck that I came across plastic surgery. Genuinely.
Okay, we'll have to dive into that because I'll admit, before speaking to you, I was under the impression that the specialties you guys were able to go into, like the core specialties, which is internal medicine, family medicine, pediatrics, OB-GYN, and that was it. But then I come across you and you're a plastic surgery physician's assistant, and that's a very intense surgical specialty.
Yeah.
So I was just like, had to blink twice. I was like, I didn't know this even existed. Like I did. So that's why I was asking, like, what are the specialties you guys go into? Like, okay, is there an orthopedic
Oh,
PA?
absolutely. My gosh. Yeah, surgery. I mean, my entire world was surgery. I hung out with all of the other PAs while we were, charting and putting in orders and whatnot. It was all PAs.
Yeah.
So at least over at Allegheny General Hospital and UPMC, the same. So a lot of surgical subspecialties really rely heavily on PAs. Different practices have different ways. You maybe work with just one physician, or multiple doctors have like a PA to support.
Okay.
So yeah, it's at each different practice's kind of discretion there, but I absolutely love procedural things, and that's why I really went into, like, I was thinking ER, and I was like, all right, well, if I'm not going to do that, let's pivot to something that I can still do something with my hands in surgery. And yeah, and honestly, Duke was the first program for PAs to come out. And it was because of some training that these people had from war, actually, when they came back, and they were like, oh, these people have been trained on these medical procedures that they can do for people, but what do we do with these folks? So they came up with the PA program at Duke University, and that kind of like bridged a gap there.
Was that the flagship program for PAs? Like that was the first one?
That was the very first one. I think it was back in the 60s.
That's crazy. I did not know that.
Yeah. So really interesting that was kind of the intention. Yeah. So it was actually kind of born of surgery, but you will see a lot of PAs in those general medical practices now. So.
Interesting. But then there's now in 2025, you guys have branched out though.
Oh yeah.
Yeah. Which is an interesting thought for people who are debating between physician's assistant versus an actual doctor, because like you guys do have a better like work-life balance in a lot of instances than a doctor would. I think we were talking about that off camera.
Yes.
And if someone wants to, get that exposure to like a surgical specialty without having to go through the years of schooling, and they're okay with the trade-off of, and we'll get into this because this is my next question, the amount of discretion that they have in that job versus if they were a doctor, then that might be a valuable career path for them. Yeah.
One of the things that really attracted me to the PA model anyways was really the versatility that they do have. Like working in plastic surgery, if I wanted to go into internal medicine and I said I absolutely hated this field, I can jump over into that tomorrow.
I know that's very hard for doctors to do. It's like you're pretty locked into your specialty.
You are exactly where you are. You don't train to become a surgeon and then say,
internal medicine. You're just like, let's
just go over there. Yeah, you just don't do that. And as a PA, you technically could if you wanted to. So I mean, that versatility really attracted me to it, and has been really useful because I was in surgery before, and now I work just in aesthetic medicine. So it's peeling back from that surgical intense piece, and it opens up so many roads. So I do think that the PA, and especially compared to nurse practitioner, because we'll talk about some of the different models too, but nurse practitioner kind of locks you in a little bit more. You do follow more of a main trajectory there, where PA, you really do have the full playing field, which I don't know, I like options.
Yeah. And so speaking of discretion, what differentiates the work you do by yourself versus the work you do with a physician? How much discretion do you guys have?
Yeah, so that's an amazing question, and it's changed over the span of the time of me being a PA. Like, I feel like the first 1 to 2 years that I was a PA, I might as well have been in a diaper.
Okay.
Like, I was just genuinely, I didn't know which way was up and down. PA school doesn't really train you necessarily for plastic surgery. I was getting pig's feet and the physician was showing me, this is how we sew. And, yes, I learned how to sew in PA school.
So you were actually involved with the I know you said you're involved with the procedure. So I guess my question is like discretion, right? So it's like, are you cutting the person open, or does the
Oh, yes. Okay. Well, I mean, that portion of it, of course, the doctor is going to be in charge of creating the plan. And they're the ones who are, doing it'll literally be a section in the charting that they were there for any of the like really important parts of the case. Like if this is going to get really technical, but if there's like an anastomosis or something that's going on and they're sewing veins together, that's something that they're doing. I can assist with it, but they're the ones, and it's their comfort level with, yes, like I know that I've watched you do this portion and I'm like, okay, offsetting that to you. So it's really relationship and trust based between a supervising physician and the physician assistant.
Okay.
But the doctor, especially with surgery, is always coming up with the plan. If we deviate from the plan of care, that's the doctor making that decision, and physician assistants are there to help carry it out. Of course, when I was seeing patients back in the clinic, I would update and kind of debrief the doctor on everything that was going on with the patients that I saw. And we just kind of like wrapped up every day going over those things. But genuinely, it's the doctor who's driving the plan. They're like the quarterback on the field. And while we might be good subs here to kind of help fill in and bridge those gaps, and help drive that ship, but that he's already, or she has already determined the location, where we're going.
But to use that analogy, you might be the wide receiver or the running back in that sense, because they might have, depending upon their comfort level with you, because if you go back quickly to that story where that preceptor of yours was showing you how to do certain procedures, it sounds like not that your discretion is entirely determined by the physician, and because I think there are things you guys can do by yourselves,
right?
You can just go in and do it,
right?
But maybe for things that are creeping up against the edge of the doctor's scope of practice, the doctor can be like, depending upon your relationship with the doctor, and that's where
in time in medicine, like your first year or two, a doctor is not going to hire a PA and go, okay, cool, sounds good, get in there, go get him, kid, go see 30 people today. That's just not how it happens. And honestly, it sometimes can happen. And I've talked to other PAs who have just been put in bad situations, and like, it's really not appropriate.
Right. So,
whenever PAs are considering their first job, they really, and you'll even see in job applications, like new grads not accepted here, so they want you up to speed sometimes in certain specialties. And that's kind of the trick of when you get your first job as a PA. But genuinely, yes, we can be independent. We can diagnose, prescribe, treat, and come up with treatment plans for these patients. But if something is looking like it might be a little bit beyond our scope, there's a big portion of setting aside your ego as a provider and just, roping a doctor in when it might be necessary, or this is, not your typical, and you're like, I don't know, something's just not right here. Let me go get another set of eyes or opinion here on this.
Have you ever had an instance where you called in a doctor in and they just take a look and there's like, Shannon, I trust you. Like, you can do this. Or is it, yeah?
Yeah. I mean, I feel like,
well, it was something that it may potentially been uncomfortable for you to do initially, and you may have needed that guiding hand and say, no, Shannon, like, I trust you. You got the skills to do this. I'm here if you need me, but you can do this.
Yeah, there were just, again, my training, and I'm just thinking back to the first few years of my career here, and there was just never a point in time. I just had a lot of amazing guidance. So, you know, he supervised everything very closely and meticulously that by the time that he was like, you got this, I was like, oh yeah, I know I got this.
Oh, okay. So, okay.
Yeah.
Okay. Got it.
Yeah, those training wheels just persisted for a long time just to make sure that everything was being done the way that, you know, he would have done it. Because that's essentially what they want you to do in surgery. And that's kind of why maybe some surgeons like new grad PAs, because they can mold them into their own habits.
I see.
And those can either be really good habits or ones that you have to break from, you know, a previous training.
Right. Okay.
But no, I mean, I think that the autonomy, it was so cool working in surgery because, you know, I would be doing, let's just say we were doing a breast reduction and my surgeon is closing one side and I'm closing the other. Am I the one who was, you know, making, like, really cutting things? Not necessarily. But there was a lot of prep and I loved the autonomy that was going on in there because, you know, there was just a lot to get through in the entire day and helping to coach, hey, resident, this is what we're gonna do. And they're telling me, oh no, Shannon, it was just a huge
And
team.
in that instance, actually, that's actually you telling a resident, or like this is like an MD or DO resident, like you telling the resident, like, hey, like this is how it's done. So there's an ecosystem I know in medicine, and we're gonna get into this in a minute. But it's not necessarily like there might be a stereotype of a hierarchy. That's not necessarily the case, though.
Right.
That's where I think that's something we definitely need to kind of dispel here.
Yeah. I mean, when we're talking about like who the different providers are, and I mean, this is huge because some people are like, I don't even know who's seeing me. And it's like, okay, well, patience, you gotta be accountable, like ask, like we're not shy to tell you what our training is.
Right.
But you know, it is an ecosystem. It's not a hierarchy. Like genuinely, when I started in plastic surgery, the nurses, they were like, are you sure you want to do that one, Shannon?
Yeah.
And I was like, oh, right. We're going to do that one. And, you know, so they were so gracious. They helped me to build up confidence, but genuinely it's a huge ecosystem and everyone needs each other in those moments.
It's a team. It's your team.
Oh, it's a huge team.
And you might have a quarterback, but like the quarterback is only so good as your wide receiver. The quarterback is only so good as your offensive tackle, right? Like
exactly.
Right. But so let's get into that. So there are a ton of different types of medical professionals. You got your MDs and DOs, which is what I'm trying to be, God willing, one day.
Yes, God willing. Good luck. Good luck out there.
Thank you.
You got this.
You've got your PAs such as yourself, but you also have your registered nurses, your RNs. You have your nurse practitioners, your NPs, right? You have MSNs, LPNs, BSNs. Just the list goes on.
Right.
So could you break down what are the differences between these different levels of medical professionals, and then where you as a PA fit into that ecosystem?
So, I mean, it really does all come down to the amount of training that goes into it. Obviously, you know, we already talked about, you know, having the 4-year program that you've talked about, and mine being 2 generally. Other programs like nurse practitioners are also 2. From the RN model, that I believe that's a 2-year associate's degree.
Okay.
Then they can go on and receive like an MSN or BSN or an MSN, and those are additional amounts of schooling. And from those, the RN or BSN, MSN, you could become a nurse practitioner too. So there are different pathways, and PAs and or DOs, MDs, and PAs. So the doctors and PAs are trained in what's called a medical model, where you learn the diagnosis, management, treatment, and they just prompt you on all of that first, where then there's the nursing model, and that's where that RN, LPN, nurse practitioner, it goes that route.
That's interesting that you said that, because that creates that does create a differentiation between the professionals, the professions, right? The ability to diagnose and create a treatment plan,
right,
which you need people to do,
right,
but then you also need people like your nurses that can just manage the patient when the doctor's not present, like you stick the IV in, making sure their vitals are good,
they
right?
Carry out those orders.
Correct.
Yes. Yeah. So, you know, it's the quarterback or that running back who's coming up with, you know, plans and, you know, for what's about to happen, but then you have other people carrying out those treatment plans. Because if we had to do it all, my gosh, you know,
we would go insane.
Yeah.
We're already going insane.
Yeah. And so, I mean, that's why it's just a really great team symbiosis, and, you know, how well everyone works together and communicates. That's where the efficient practices come in.
I think we spoke like nursing, nurse practitioners is how much of schooling is that?
That's going to be an additional, typically 2 to 3 year program after they already have a nursing degree.
Oh, geez.
Yeah. So, I mean, they've like the nursing degree, RN, is 4 years of undergraduate. So then you go and take your NCLEX. I have plenty of friends who went that route. And then later on, and this is really interesting. So to become like a nurse practitioner, you need to have like ICU experience, whether that's going to be like cardiac or, the ICU experience actually was for CRNA. That's what it was. So, yeah, nurse anesthetists. That was their ICU experience, but family nurse practitioners. Anyways, there's a lot of different training models that you can go into. But with nurse practitioners too, one of the important things is that you can be independent then. PAs always have to work under like a supervising physician. So there is always that kind of relationship going on. Does that make sense?
And that's not necessarily the case with an NP versus in a doctor. That's not necessarily the case. Okay.
Correct. Nurse practitioners can be autonomous. They could even own their own practices if they want to, like a family.
So they have more. It sounds like they can have more discretion than you guys in certain instances. Again, this is very context dependent.
I genuinely feel like the discretion itself is, yeah. I mean, if you have the relationship with the physician and it's very trusting, then you can have the same level, I feel like, of discretion generally. It's just about, I guess, where your mind wants to go with it. If you wanted to own your own practice,
then you're
that
more
would
business
be different.
Minded.
Right.
Yep. Okay.
Yeah, because I do feel like I know quite a few nurse practitioners who do have that kind of savvy business mindset, and they want to own their own thing. And then any PAs who I've known who have gone that route need a supervising physician agreement.
But that's part of the reason why you chose that profession, I would assume, is that's not part of your goals.
You're right. And also, I mean, this is, we kind of touched on this a little bit earlier, again, off screen, but like the liability thing.
Yeah, could you dive into that?
Yeah. So, I mean, at the end of the day, when I was working in plastic surgery, I knew that I was carrying out orders and treatment plans that had been set, or, as I went on, I was kind of developing my own. But at the end of the day, it's the doctor who was taking the risk. And that's why I feel like I understood why he so closely monitored everything when I first started, because that is his medical license. He's sticking his neck out on the line.
He's trusting you.
Yeah, exactly. And like, I have medical malpractice insurance, as does he. But at the end of the day, I am operating under a context that was kind of set up by them in a way.
Yeah. So I think it's not to say that a PA license protects you from malpractice. That's not what we're saying.
Right.
But what we are saying is that because you're under the guidance of a physician, it's ultimately the physician's call. So more than likely, if something were to go wrong, whether like accidental or whatever, right? It's the chance the blowback is going to largely be.
Yeah, I mean, if a doctor makes a mistake, it only comes back on the doctor.
Right.
If a PA makes a mistake, it's coming back in the context perhaps of the doctor too.
Right.
So at the end of the day,
it's a double whammy. It sounds like actually.
Yeah, it's a double whammy for the physician. So I do think that when we're talking about stress levels, I do think that it tends to probably be a little bit higher for doctors in that reason, because they are initiating that whole plan of care, and they do know that it does eventually maybe fall back on them.
Yeah, well, but it makes you look at the relationship between you guys and physicians in a very different light now, because it's not just like I'm telling you what to do, like just do it. Like no, there's like a listen, like I'm trusting you here, like
Yeah.
So when we're gonna work together and do this, absolutely. And we just talked about like advantages of pursuing one degree over another. So like MPs have like a there's more discretion and advantages for that degree, and then for PAs. So when I thought of medical professionals before this conversation, stereotypically, what did I think of? I thought of like the show's ER. You just see a nurse in the ICU, or you just see like a cardiologist, right? But then I met you. And you work in aesthetics, which seems to me like a different ballgame. Would you agree?
Yes and no.
Okay.
I think that it's definitely a little less stressful than working in an ICU.
Okay.
A lot less stressful. All of our patients come in and everything is very elective that they're doing.
Okay.
Where
What the patients are asking you to do.
Yes.
Okay.
Yeah. So the patients electively come in of their own free accord, of their own free will. Of course, when I was working in the hospital, in plastic surgery, Mr. Jones didn't choose to get into a motor vehicle accident and now he needs this whole plan of care.
Right.
He didn't choose to have
get into
the
motor
hand
vehicle
attacked by chainsaw. I mean, maybe it kind of did, but
Mr. Jones, you're here again. It's like, nah. I love my motorcycle. What can I say?
Oh my gosh. I'm so against motorcycles now after working plastic surgery.
Really?
Oh my God. Yeah. Yeah. It's no bueno. But at any rate, I think that working in aesthetic medicine is a beautiful blend of science and artistry. And I kind of got a hint of that in plastic surgery. Not kind of, I really got a strong whiff of that when I was working in plastic surgery about just, blending that artful eye together. But it really reduced the burnout that I was experiencing.
Okay.
When I was working in the hospital, which is huge for anyone working in healthcare, in my opinion. And when I did teach at Carlo, I taught all my students about burnout and recognition of it.
I didn't know you taught at Carlo.
Yeah.
So I should be calling you professor.
Yeah, that was fun for a second. I did it for a year.
That's really cool.
And so I mean, lots of different pathways that you can go with being a PA. But yeah, shout out Carlo.
Yeah.
But yeah, so where were we? We were talking
aesthetics. So like
so working in aesthetics, it just it's a really unique thing because I do feel like I get to develop my own treatment plans.
Okay.
These are like, of course I have a supervising physician and there is chart review, but I know how to do Botox at this point in time in my life, been doing it for 8 years. And so they're, very easy, relatively low risk medical procedures that can be done. Patients love it, and out they go on their way. But if I personally like to treat the aging face kind of like a medical problem.
Okay.
And I break it down to patients too. And I'm like, well, let's think of aging as a disease process. What's going on here so that they can understand why we might use more than one thing if they want their best result. So I really do appreciate breaking it down to people in a scientific way.
Mm-hmm.
And all my reviews, they're like, Shannon was so thorough. And I'm like, I hope that's a good thing.
I mean, and we'll dive into that too, because it's part of the reason why I want to go into longevity medicine is when you can conceptualize aging as a disease process. Like it's a natural part of life.
Right.
But when you conceptualize it like that, then you're like, oh, okay, wait a minute. So then there are things we can do to slow this down.
Right.
If not reverse it.
Right.
Which then I get nerdy about.
Yeah, exactly. Same. Which is why we are where we are.
But aesthetics, does aesthetics have its own ecosystem as well?
Oh, yes. Yeah, definitely. It does have its own ecosystem. So, everyone looks the same in an office. We're all wearing the same black scrubs. So it's kind of like, well, who's doing what?
Right.
But generally, you'll see PAs, nurse practitioners, nurses, and even estheticians. So it's a beautiful blend of people who have different focuses. So PAs, nurse practitioners might be a little bit more focused on injectables. Nurses might be focused on injectables like fillers and Botox. Whereas estheticians are more skin focused.
Okay.
So they also do some lasers as well, but maybe they're talking to you a little bit more about skincare and doing facials, extractions, treating someone's melasma. That's a medical condition with, the pigmentation that can go on in the skin. So they're really skin forward. Okay. I personally practice and do all of it because I like to have all my hands in all the pots and I love lasers and I love this and I want to know all of it. So that's just personally how I choose to, how I like to do the care because it mixes up the day.
As a PA in an aesthetic practice, I'm curious, how do you use your diagnostic ability in your practice?
Sometimes for telling people, hey, what you're actually talking about is potentially skin cancer and you need to go see a dermatologist. So diagnosis there. But yeah, I mean, my charting now is like patient complaining of mild dynamic lines on forehead, recommend XYZ and, then see them back and evaluate the results, and adjusting dosing for Botox, because Botox is a medication and should be dispensed and prescribed. It's not just one size fits all. So, understanding the anatomy that goes on in the face, and then dosing medications, things like that.
And so would you say like where you fit into that ecosystem is, like you said, you do have your hands in all the pots, but then there are some things that as a PA you're able to do solely versus say like an esthetician?
Yes. Yeah. So injectables again. So if you're administering medications, that's going to be where PA or nurse practitioner would kind of fall into that role, or nurses, because they can do injecting too.
I'm curious. You said in aesthetics, you guys all kind of look the same. Have you ever been mistaken for another profession?
Yeah, absolutely. There are reviews online. They're like, my esthetician, Shannon. I'm like, I gave you my business card and I introduced myself as a physician assistant, and that's so much more schooling, but that's okay.
Of course.
Yeah. So, I mean, it happens just the same as it happens in the hospital. I come in and they're like, oh yeah, my nurse Shannon. I'm like, yeah. Okay. But again,
I can imagine it's a human emotion. Like it's a little frustrating.
And because how much schooling and time you've spent on things. So, I'll always just kind of mildly reframe, and I'm like, well, I am your PA, and just so that they also understand, because I think there's a big neglect of people outside of the medical world who they don't understand who they're seeing. And I understand that it's confusing when they're in the hospital and they're seeing so many people, but it's important to remind people, hey, this is where your care is being driven from. This is 8 years of schooling that's telling you, hey, we're going to do this. Right. This is the treatment plan, versus someone who maybe just has like a 6-month degree, know? So I think that's kind of where that power stands in.
And that's not just, and we're not trying to say I just good or bad, or bad or less than any other, but at the same time, it's like you went through a considerable amount of schooling and training and blood, sweat, and tears. Yeah. And it's just like to be mistaken for something you're not. And I think anyone can relate to that feeling. I've done that. I've had this happen to me a couple of times. Where it's actually happened to me where in the reverse, where people maybe because of the way I speak, and I try to sometimes be technical, and they're like, "Oh, doctor," I'm like, "Dude, don't."
Oh yeah.
No, don't call me a doctor.
Yeah.
One day, but
I'm
not. No, don't tell me. Yeah.
Oh, I've also been mistaken. They're like, "Oh, Dr. Masterson, you were great," and I'm like, "No, I'm not. That's very kind.
I don't have that kind of malpractice insurance.
Yeah.
Not me.
That ain't me.
Oh man. Well, what's funny is that, when we look at, I'm trying to be a doctor, and God willing, that's going to happen one day. But I just didn't know that there were so many different medical professionals, and before talking to you, that fit into this ecosystem. And up until this point, I didn't know that. It sounds like traditional medicine and aesthetic practice, they have differences, but I thought they were pretty dissimilar up until now. So,
I did too. Yeah. I really did too. Honestly, when I was leaving the hospital, I was like, I don't really know if this is going to scratch that itch for needing to care for patients. But, really seeing people's confidence improve, and seeing, treatment plans get carried out and your patient improving by the plan that you set forth. I mean, it's still very similar in that way. So it really does do that for me too. And I really do love getting to see my patients progress. And that's kind of why we're all in it, There just happens to be a much lesser side effect of burnout when you can, limit your hours and be a little bit more in charge of your schedule. And there's just, I hate to use the term work-life balance, because sometimes I allow, work to be more in balance or life to be more in balance, so it's
the scale can shift depending upon the day. I think it's if in total your life is balanced and you have the time for the things you need, and you have time. This is just strictly speaking for myself, but I found that when I can still make time for the things that restore me to then go back into work, then that's work-life balance for me.
Right. Exactly. And everyone has their own little different titration of what feels right for them.
Yeah.
But I mean, just speaking about working in the hospital,
It's a lot.
Yeah.
I see it. I'm just like, I'm currently a tech.
Yeah.
But I see, as much as I work, like I see nurses and professionals such as yourself, and I guess I'm tired.
Yeah, and I think that it comes down to confidence too, with people knowing what their limits are and being able to dictate that, and sometimes recognizing when you're in a practice that's not really supporting that. I feel so bad for residents. It's so grueling.
That's a whole nother rabbit hole. That's a whole nother conversation. But we talked about all these different medical professionals. You also mentioned that you wanted to be a PA since you were in high school.
Yeah.
So of the numerous professions we've spoken about, why did you want to become a PA?
So actually this stemmed from the most traumatic thing that ever happened to me in my life. I was in a huge car accident at the age of 13. Drunk driver over on Route 28 hit us head on. There were 2 girls in that car. One of them died. And
in the car with you? Or
that was in the oncoming car. There were 2 girls in that car. So I was age 13. And just actually went out for my birthday, turning age 13.
Oh my God.
And my entire family was in the car. So my parents, my sister, and I, we were all in the car. That car hits us head on because, again, drunk driver. And my entire family almost got ripped apart in the matter of moments.
Your sister, everyone's okay, obviously.
Yeah. Thank God. But my mom, that accident happened in November. And honestly, I don't think that she came home from the hospital until April or May of the following year, because of all the rehab that she had to do. Fractured so many bones, so many bones. And actually the biggest pull and why it's so personal to me is because we had the same physician, Dr. Tarkin. He is an orthopedic surgeon, operate on us in the same night. So I fractured a part of my hip and he took care of that. My mom had several surgeries. So I just kind of felt like we were bound and tied together. My dad sustained several injuries and so did my sister. So my mom's were just most severe, and we had the same surgeon in that night. And I just knew I wanted to do something because that kept my family together. So that event really just kind of glued and solidified what I wanted to do with my life's purpose. So up until my junior year of high school, I was like, I'm going to be an orthopedic pediatric surgeon. And that's what I was going to do. And then my friend, who actually was my freshman year roommate at my PA school or graduate school, Catherine, she was like, have you heard of this thing called PA? And then I looked into it and I was like, whoa.
Just do this.
Yeah, I'm going to do this shorter route and I can work in surgery. Perfect. So I thought that I was going to go into surgery, and then I really loved ER. I thought that I had a job lined up there, and it was pending someone getting deployed. I was going to work up at Meadville Medical Center in the ER because that's where I had one of my rotations.
Okay.
And oh my goodness, it fell apart right as I was graduating because he wasn't getting deployed. I had papers, I had signed things, I was going to have a contract, I had a salary, everything was looking good, and I was feeling good about graduating PA school. All I had to do was pass my big exam and get my license, and we're good to go. And then they were like, oh, sorry, that job no longer exists. He's not getting deployed. And I'm like, oh.
And you're like, no.
Yeah. And I'm like, oh my gosh, all my other friends have jobs lined up. I need to apply to all the positions in Pittsburgh. So I did. And, nowhere in Pittsburgh was going to hire a new grad in the ER, level 1 trauma centers where real, really big stuff is happening. That wasn't going to happen. So I applied to all the surgical positions because I really like surgery too. And I was like, I don't know about this plastic surgery one. And I just applied to it.
And you got it?
Well, yeah, I interviewed for it. And then the surgeon liked that I had a research background. So he was like, okay, cool. And then we went forward with it. And it was the best thing that could have happened to me as a young PA because I really felt like I got an immense amount of training from that job. I spent 4 years there and it was just amazing. I just really had the right amount of training.
Just to really quickly tie it back, do you think that if you were a physician and you made that move, because we just talked about how you guys have a bit of have an easier time moving across specialties like that, I probably wouldn't have happened.
No, and honestly, it's something that I really, in talking to people who are considering different professions, I do have friends who are physicians and they are not happy. So I think that it's something that, you really need to think about and take seriously. It's a life calling. There needs to be a deeper reason why, and that's going to connect you and tie you down and root you, because it's a lifestyle. You decide, you submit yourself to the service of people. And it's really a vocation in that way, in my opinion.
Well, speaking of calling, and similarly how you had a traumatic event that led you to medicine. The traumatic event for me was I lost my mom to cancer in 2017.
Oh my gosh. Yeah. I had no idea.
Yeah. So first time I'm telling you. So it was 2017. She passed away from colon cancer.
Wow.
And, what's kind of sucked about that is that she didn't have any comorbidities. She did yoga. Like she was healthy. But
that's awful.
Yeah. And, similarly to you, like after that, I was like, I'm going to be an oncologist. Like that was like, like understandably like putting myself like into that like mind frame, but also kind of pigeonholing myself. But then, you go through college and you go through life, I had, my gap years and had a couple of like perspective changes. And one of the things that I was looking at was like, how do people get cancer? Like, why do people get cancer? Or why do people get chronic disease at all? And then that's kind of what led me to longevity medicine. Cause I'm trying to understand like if you can do the things to prevent or to reduce the chance that you're going to get a chronic disease, if not prevent it outright, then why don't we just do that?
Right.
And then that kind of leads into another conversation about how healthcare is practiced in the country. But
even interestingly, I mean, my sister, and I will entertain this tangent. My sister, she has her master's in public health, and she talked to me years ago about, how the model of medicine does need to change into a preventative route. But, not to get too hippy dippy here, but there's not a lot of money in prevention, and there is more money in treatment.
And to a degree, it's like you do what you can, you work within the system, and when you can carve out your own niche to practice medicine the way you want. Like I've seen many providers do that, and I think it's awesome. And that's not to say that people in sick care aren't doing they're doing their absolute best. And for what it is as a sick care system, it's good.
Yes.
But younger generation, from myself, you just start to wonder, oh, maybe is there a better way of doing this?
Right.
That's just me based on like my own life experience.
Yeah.
Because I know like my mom's oncologist did the best he could.
Right. Right. And I mean, cancer is just such an ugly disease. Having worked with so many really wonderful patients when I was working in plastic surgery, who had breast cancer, had neck cancer, colorectal cancer, there wasn't necessarily a good reason as to why, what the cause of it was. And it's just devastating. There's nothing good about it. And I'm so sorry to hear that.
Yeah, but
that's kind of your why.
That is a lot of my why. It's but it's just ironic. It's ironic, and it's maybe poetic in a sense that you have this traumatic thing that happened to you, but in the memory for my mom, and then also like thinking about what I want to do with my life. Right. Because I know like my mom wouldn't want me to do anything that I didn't want to do. Like she's like, if being an oncologist makes you like miserable, like don't do that because I passed away from cancer. Like don't do that.
Yeah.
So I'm just thinking like, okay, like this is the spark that kind of lit the fire to go down this path, but it's like I have to make it my own. And this kind of again what led me to longevity.
Yeah, exactly. And I mean, like even so I had something traumatic happen. Here I am dosing people up with Botox.
Yeah, but it's your way of.
Yeah, it was the path that I found. So everyone finds their footing in what drives them and makes them passionate. But it's a really beautiful thing to come back to. I had that on my graduation cap. Remember why you started, and it's just that. Hey, you talk to so many healthcare providers, and it's something awful usually that happened somewhere along their life.
That is a common theme I see. It's just like it's poetic. That's what I'll say. It's just it's kind of it's like Batman. It's like the thing that this terrible thing happens to him, but then he uses that pain and he just does something good with it. Yeah. But on a lighter note, I do want to bring us back to some warmer memories, which I wanted to ask you. What were the best moments at PA school?
Oh my gosh. Best moments of PA school, a lot of the camaraderie. So, my classmates who I got to go through with, that was amazing to make those friendships there. And then honestly, just like that experience of being out on the different clinical site rotations and seeing what I really connected the most with.
Yeah. Which at the time was ER. Right?
Yes. At the time was ER.
At the time it was ER.
Yeah. I liked surgery too. West Penn's burn clinic was, oh man, that was intense.
Yeah.
Oh yeah. Yeah. So, I mean, that was a big standout for me and kind of made me start liking really surgical procedural things.
Oh, so you worked in a burn unit.
Yeah. I worked in West Penn's burn, well, not worked in, but I did a clinical rotation for 6 weeks at West Penn's burn clinic, and holy moly, that was a lot to see.
Sure.
And just really, burns are bad. Burns are bad.
But I know like burn victims also, they can get a lot of practice surgery, so they choose to, and so so I wonder, was that a common link that you saw? So it was a piece of ER that was carried with you in a sense.
Yeah, yeah, and I mean of surgery too, because when I went into plastic surgery, we continued to do mild amounts of skin grafting, and well, yeah, we did do skin grafting, and I was like, oh yeah, I did this very intensely for a good period of time. So I mean, honestly, really getting to develop yourself a little bit more professionally, make those connections, and develop your network, that was really exciting to do during PA school as well. Oh my gosh, one of the standout moments too.
Okay.
I did Life Flight.
What's that?
So Life Flight is the helicopter that goes up and.
Wait, is that the helicopter? See, like in this, like when I'm walking past like Presbyterian, and were you in the helicopter?
Yeah. Yeah.
Shut up.
I was there doing runs with them that day.
That's really cool.
Yeah. I say cool, you know, kind of like, you know, there are two sides of that coin, because if you're in that helicopter, something very bad is happening.
Fair point.
Yeah. Yeah. But you know, getting to see those patients and like the healthcare providers so knowledgeable, like knowing which medications to push rapidly, and I mean
on the helicopter.
Oh my God, yeah, yeah.
That's intense.
Yeah, it was so intense, and people just honestly having the worst moments of their life being in that helicopter before they got to a hospital to receive care.
Well, you think about like what happens to that person that requires they have to get a helicopter out, but there's a distance to get them to but also probably has to be something like
and sometimes too, it's, you know, hey, they were at this lower acuity hospital and they just needed to be transited to something that was higher acuity. But again, the things that people are getting transferred for are no joke. So yeah, that was pretty crazy. But that was definitely a standout moment. It was like the ride there, you're like, wow, pretty view. And then you're going back and you're like, oh my God,
wow, pretty view. It's like, oh, wow.
Yeah.
So then when you went from ER and then that kind of fell through. Then you went to plastic surgery.
Yes.
Describe that experience. I know you touched on it a couple of times.
Yeah. So plastic surgery, you know, we did anything from, you know, cancer reconstruction, motor vehicle accident, those kinds of reconstructions. We were really doing some super cool cutting edge procedures. So, you know, I could get so technical about it, and anyone who knew me at the time in plastic surgery was like, okay, Shannon, we know you love your job. But you know, then
nerd alert.
Yeah, major nerd alert. I could go on. I could have a whole podcast on that. But breast cancer reconstruction really resonated with me. And that's kind of what has maybe shaped why I like aesthetic medicine. But really helping to build people's confidence. There was one woman I still this day remember, we did a breast lift on her, and hers was actually covered by insurance, which usually does not happen. But anyways, hers got covered by insurance. We did it. At her follow-up, she was crying, hugging us, and just seeing, she's like, you have no idea, this gave me so much confidence back in my life. And then for women going through breast cancer reconstruction, which is actually anywhere between typically 2 and 4 surgeries spaced over the span of 1 to 2 years.
It's not just one?
No. It can be, but traditionally it's between 2 and 4 surgeries. Okay. Yeah. And they are covered by insurance. So this is just my little piece to educate the public that, you know, breast cancer reconstruction and revisionary procedures are also covered by insurance as well.
As a guy, like I can only imagine how that feels. Like this.
Yeah. And I mean, just that whole process of like, you know, when a woman would get diagnosed with breast cancer, the only thing that they want is, I want it out, I want it out, I want it out. And that's the only focus, is treating, obviously, cancer. Right. And then after that part is taken care of, they're like, okay, wait, aesthetically, what is also going on? Breast cancer reconstruction improves the psychological outcomes rather than someone just going through a mastectomy without any kind of reconstruction, which is a perfectly viable option for patients as well. But that being said, breast cancer reconstruction, seeing those patients through, those were my ladies. I loved them. We saw them back so intensely, and I really developed a lot of relationships with them there.
That's amazing, Shannon. That's really cool.
Yeah. So that really resonated really, really hard with me. And then when I swung into aesthetic medicine to get a break from working in the hospital, that was...
That's what I wanted to talk to you about. So you went from plastic surgery to aesthetics. So what was there a moment that motivated that change, or was it like a gradual thing? Like kind of what sparked that?
Yeah. So by year 2 of working in plastic surgery, I knew that the workload was pretty, up there. And it was a lot to handle. I thought it was me. I thought it was just me, and I just needed to get more efficient at my job. And then by year 3, I was like, wait a second, I'm actually like not bad at my job. And I'm doing things as efficiently as I can, but it's still a lot. So, I pushed for a couple of different things like, hey, let's get some more supporting staff, this, that. I was met with a lot of no's. And at that point in time, by year 3, I really did want to leave. The doctor that I worked for, he was like, please just stay one more year. I'm going to be here for one more year. Just hang tight for one more year. And I was like, all right, I love working for you. I'm going to stay. And then when I transitioned over to aesthetic medicine, I'm not going to lie. I was working for a new physician at that point in time because first physician exited, new physician enter scene. I loved working for Shay already. And I was like, oh no, I can't have this happen again. Right. So I was like, I really need to step out. The aesthetic place had called me up and they said, hey, do you want a job? And I said, absolutely. I'm burnt out. It didn't really seem like the hospital was taking that seriously. So that's when I transitioned away from it because I knew I wasn't showing up for my patients how I really wanted to. And, really diving all in, eat, sleep, breathe, hospital, and, that patient care. So it's not how I wanted to show up. So I transitioned over to aesthetic medicine at that point in time. And honestly, I cried to my new supervising physician, Shay. I was like, I don't want to go into the med spa. And then he's like, yeah, I cried. And
I just imagine like a kid's like, I don't want to go.
Yeah, I don't want to go. I love it here. And then he's like, Shannon, you might like it. And, if you don't, you can always return. Like,
that's a good point.
So he was a really good, mentor to have at that point in time in my life too. So, the transition, I wasn't sure if I wanted to go dermatology or what, but I ended up in aesthetic medicine and it was exactly what I needed in my life. I genuinely believe that. And the Skin Center has been really great to me. So,
and I can only imagine because it was an instance of where you had a good relationship with your supervising physician. You liked the work that you were doing, but just the workload was just too much, and that was affecting your ability to show up for your patients.
Yeah, I mean, I was going through, some personal life things at that point in time too, and I just knew that it was all piling up too much, and I was getting really stressed out, and all my family, like, what are the signs that you should leave a job? If everyone in your life is telling you that you should leave a job, you should probably leave that job.
Leave your job.
Yeah. So when I finally did like ease up in that, and I was able to, exercising is really important to me. And I really slacked while I was working in plastic surgery because I just didn't prioritize myself.
Oh, when I don't go to the gym for like a couple of weeks, I get depressed.
Yeah.
It sucks.
Exactly.
You feel, I feel unhealthy.
Yeah, exactly. And like my brain just is not operating at the higher capacity that it can be. And you just, I don't know. It's just like not good.
There's actually a study on that, and I'll have to send it to you after this podcast, but they were looking at exercise, and it's shown that when you do resistance training, your brain actually releases this compound called BDNF. It's like brain nootropic factor.
Whoa. Oh yeah. Okay.
So there's something to the phrase that exercise is good for your mind.
Yeah.
But now we're actually looking at that like neurochemically, like that's actually might be true.
This is why you have this podcast. This is the info that we need.
Lift heavy things, guys.
Yes.
Lift heavy things.
Yes. Yeah. Generally like exercise, and that's, also the thing too about like just medicine in general. A lot of it is just counseling people on things that seem simple and are kind of, if you live a healthy lifestyle, it makes sense to you, but it doesn't make sense to everyone, and trying to like coach your patients on just improving their life generally.
Yeah. And you're in the business of people. It's something you have to acknowledge is that not everyone's going to follow your guidance. Yeah. And that's just something you have to. And you can't change that. You can't change that. That ultimately that has to be a thing that person, that person has to do. That's a decision they have to make. Yeah. So, and that's something that I'm trying to mentally prepare myself for. That it's just something you have to be okay with. It's
Yeah.
just part of the job.
And I feel like it's kind of part of the game too, is like learning, how are you going to get through to that really hard patient? Is it going to be with humor? Is it going to be with emotionally connecting with them? What is it going to be?
It's communication at the end of the day, right? It's how do you, there's 100 ways to say the same thing.
Mm-hmm.
You look at the person in front of you and say, okay, how do I say this in a way that's going to resonate with them? And it's the best percentage chance that they're going to make changes that are going to be beneficial for them.
Right.
Obviously, like I want them to, there's a selfishness in that. Like I want them to follow my advice, but at the same time, it's, I'm also saying this for their good as well. But yeah, so it all comes down to communication. I'm curious.
Mm-hmm.
We talked about discretion earlier.
Mm-hmm.
What's the discretion difference between you as a plastic surgery PA versus an aesthetic PA?
Oh, it's much more independent now.
It's much more independent now.
Yes.
Okay.
So, working in plastic surgery, I always just wanted to fill the supervising physician in on, hey, this is what's going on with so-and-so who's, case we just did a week ago. Oh yeah, she got her drains out, or, oh, this is progressing nicely. And, oh, I'm not so sure about this. I really want you to look at that either now, like with some clinical documentation that I took, so there was a lot of communication there. Now, my supervising physician, I don't talk to them about what Botox dose I'm putting in someone's face. I don't, if I have questions, my medical director or supervising physician is literally only a phone call, text, or email away.
Okay.
Not really text. That's the, hey, will you, talk to me? Because HIPAA. But as far as the supervision there, they're very supportive, but generally there's not much that I have to raise my hand about.
Okay.
If there is, there certainly is the patient who comes across my way and I'm like, oh yeah, should we consider, someone's lupus and their treatment of XYZ?
Oh yeah. Okay. Yeah. So probably should.
Yeah, exactly. And I'm like, hey, do you have any thoughtful recommendations? Yeah. This is the research, this is the literature, but hey, is there anything that, we want to do to, ensure that this is the best possible outcome for this patient in the safest way possible? So it's really just a safety kind of thing at that point in time. And we do journal clubs, so that we stay on top of, covering different topics, which that's driven, by our medical director.
That's great.
Mm-hmm.
That's actually, because it's educational the entire way through, not just for the PAs, but are your estheticians and your NPs also in on that too?
Oh my gosh, yes.
Oh,
yeah.
so that's,
the entire company. So everyone gets to, listen in on that. And there's, a lot of ongoing education, which, you understand that there's continuing education requirements as a physician too.
It's not even that. It's there is a statistic. I'm not going to quote it exactly because I forget the exact number, but basically it's like medical knowledge quickly becomes outdated because we're always finding new things. There's always new research studies, and when we talk about drinking from a fire hydrant, that seems it's not just the case in school; it's also in the real world. You have to stay on top of this stuff so you can just do better by your patients. Yeah,
exactly.
And I think I like the fact that, because we talked about discretion and scope of practice, and even though like an NP or an esthetician may not have the diagnostic ability to the degree you or the supervising physicians have, that's still knowledge in their pocket. So if something were to come up, they could call you, or they could call your guys as supervising your medical director.
Yeah, and I think it's a really cool point to bring this up to other people in the company and say, hey, we actually have an opportunity here. Though people are coming in here for aesthetic procedures, women are more likely to maybe come to their aesthetic procedures 3-4 times a year than they are to go to their primary care physician. So recognizing a couple of hallmark things that are hey, you might want to actually go follow up with so-and-so on this. So, making appropriate referrals is a big part of, in my opinion, what I get to do too.
It's really cool.
Yeah.
So one of my previous guests was a psychiatrist. This is my second episode. It was my friend, Dr. Agam Dewan. And he's a child, adolescent, and adult psychiatrist, and he practices holistic psychiatry, if you will, looking at the biological factors that underlie a lot of psychiatric conditions, a lot of mental health disorders. And when you treat a mental health disorder as a brain issue first, rather than the way I would phrase it, it's like an ethereal mental health condition, and you just give them a pill. which sometimes is required by the diagnosis. When according to him, sometimes it's not. You can just you can actually use supplementation, exercise, whatever. But when you treat something as a biologic, you see better results for your patient. However, I think there's something to be said about that. There's an overlap between aesthetics, longevity, and psychiatry or mental health as a broader term. I think there's something to how a person feels about their appearance. And then that creates a feedback loop in their brain. So their brain's doing better, and then the rest of their body's doing better. It's like the brain-body connection there. Have you ever seen patients that come to you for an aesthetic procedure, and then maybe they come back, and you can see like they're physiologically healthier?
Oh, yeah. Especially in plastic surgery with, like I said, the option to reconstruct is definitely, has positive psychological outcomes. But the same is true of Botox. There are multiple studies, and we have to be careful about how we look at these studies because correlation is not always causation.
Correct.
But there is a reported better mental well-being with having aesthetic procedures done. They did find so with getting regular Botox, people were experiencing, and especially like with TMJ Botox. So in the temporomandibular joint here, and having like hypertrophy or overgrowth of that muscle where people are constantly clenching and grinding can contribute to a lot of headaches and just tension that they feel. Patients will report decreased levels of stress with Botox. So there are some really cool applications between even aesthetic medicine and plastic surgery and just kind of like mental outcomes for patients. But, to the same end, we also have to consider people's mental states when they come to us. For example, patient having body dysmorphia or some sort of disrepair in how they perceive their own body. We have to be careful how we select those patients because nothing that we do actually improves that condition. So if you feed into it, it's almost unethical.
It's not, I wouldn't say it's almost. It is.
Yeah.
It is unethical.
You're
taking advantage of their condition.
Exactly. So, it just never gets better. So you really have to learn, patient selection and counsel your patients appropriately on what they can expect after procedures too. I constantly say that I'm a professional expectation setter. That's all I do.
And I think that's great. And I think it goes to a larger point where I think aesthetic procedures can sometimes get a bad rap because when the stereotypical reason why people get them is for vanity's sake, whether it be, getting a hair transplant or getting, breast implants, what have you. But there's actually physiological benefits to getting these, and physiological and mental health benefits to getting these procedures done. We just talked about Botox being used for your TMJ. You spoke earlier, you have patients that got breast cancer, got their mastectomies, and then they look at themselves in the mirror and they're like, hey, I want to try to get back to what I had before, right? And then I'm sure that's playing in their mental health. Right,
exactly. So, starting that reconstruction from the get-go can improve psychological outcome, but, options to reconstruct later down the road. It's just, they're all psychologically very sticky situations, especially when we're talking about reconstruction. We can also talk about amputations, exactly, like plastic surgery
and all that.
Yeah. So there's a ton of connection between the medical procedures that people are undergoing, their psychological outcomes, different medications that all play into it, and then we also have to take into account people's own unperceived things. So I think it's a really beautiful blend that I get to practice now between science, artistry, and mental well-being.
Yeah. There was a quote from it was a plastic surgeon in Vegas. It was Dr. Chris Corsandi. And I like this quote. And I think I think for you, it definitely still applies as well. It's as a plastic surgeon, or maybe in your case, a plastic surgery PA or an aesthetic PA, like in anything regarding that realm of medicine, the way he phrases it is, you are a psychiatrist with a scalpel.
Yeah, I like that. It's true because I mean, you have to really try to put yourself in your patient's shoes, and like your level of empathy really plays out there because you need to understand to its core. If you are going to alter someone's body, you need to understand to the core what it is that they want changed, how much it is that they want changed. You know,
I think there's also like you're playing with perceptions. So what they may perceive as I need this change to this degree, and then when you look at it, it's like,
yeah.
Maybe not. Maybe we can play with the dosage or the how much change you actually need and still get the desired effect for your mental well-being. Would you agree?
Yes, entirely. I mean, like something that just pops up really easily to mind with aesthetic medicine is people who come in for like continual lip filler. And I'm like, people will come in and they're like, so more. And I'm like, I know you haven't had it in a while and you think that you should, but that is not why we're going to do it today. Because actually, by my own perception, we're not going to do this today. And actually, the only thing that I would offer you is getting dissolved. And people get so upset because they're financial investments. You know, it's something that they're paying out of pocket for. And they think, oh, no, but that's not cheap. And I'm like, yeah, but that doesn't look good, you know? And I think it's hard conversations and having honest conversations with patients and keeping them in line with, hey, don't just trace a trend. The number of times people have showed me a Kardashian lip, oh my God, I never want to see it again, ever. And I'm just like, please, you have your own anatomy. Can we just respect that?
Yeah.
So yeah, it's a lot of counseling. It is so much counseling.
Well, speaking of procedures, we've been dancing around this enough.
Yes.
You know, I want to ask you about Botox. I know that's your wheelhouse.
Yes.
So
very much so.
For the audience that may not know, can you explain what Botox is?
Yeah. So botulinum type A toxin. So it's an FDA approved in the treatment of, you know, lots of other medical conditions, but for the sake of me and my sanity today, and keeping things on track.
Yeah.
It's largely used to treat lines on the face. So whether that's the 11s between the brows or worry lines on the forehead, the crow's feet around the eyes, and there are a lot of other applications too, but those are some of the FDA on-label applications of it. Now it's so fun when people like finally come in for the first time, trust you with the procedure. You dose it appropriately because you're like, well, do you just want a little bit? Which most people are like, yeah, just like the least amount possible, as conservative as possible.
Minimum effective dose, right?
Yes, minimum effective dose. And I love finding that for people and then seeing them back and they're like, wow, that did get better. And then it goes away and then they come back. And then it goes away and then come back. So it's this fun cyclical dance that we do. But it's really cool to counsel people on like what they can expect with it. If patients wait much, much, much longer, those lines that they're forming with the dynamic movements of their face become etched, and then that constitutes other aesthetic procedures to help combat those.
Interesting.
So, it's really cool too, because I went to this conference over in San Diego. It's called Plastic Surgery, The Meeting. I went there a couple of years ago, and they were talking about people's perceived emotions. And, you know, people keep saying I look tired, or people keep saying I look angry, or people are constantly asking if I'm okay because I look worried.
Right.
And it's interesting which lines correlate with which emotions, and then which ones people want to treat based off of maybe feedback they're getting from other people around them. Does that make sense?
So if someone were to say, hey, you just have an angry face or like a mean mug.
Yeah.
And you're thinking, all right, well, I got to see Shannon.
Yeah,
get some Botox.
Exactly. And they're like, well, I don't know. I heard that Botox can do something with that. I don't really know what it is. And then I get to go off my whole
Botox
soapbox.
And anger management classes.
Yes. And yoga and stress reduction. Yes. Yeah.
Mind fuel. And,
yeah, exactly. But yeah, no, I mean, Botox is a really cool aesthetic procedure to do. Fairly low risk and really, really, really high patient satisfaction. So it's always kind of fun when people do want to do it. And I know that there's such a stigma around it, and you think that you're going to not look like yourself, but I have it. I just can't make an angry face. This is me giving you my best angry face.
We spoke about this off camera because like I actually, until you told me, I didn't know you have Botox.
Exactly.
And then I was like, okay, now, but it's like you tell me and now I can see it, but it's subtle.
Yes.
It's subtle.
Yes.
Like you can people, she can still move her face. Like she can still move her eyebrows.
Yeah, we can still animate. Here it is. I just can't look angry. And actually, there's more of a psychological impact with the fact that you can't make a movement. You feel less of that emotion. So there actually are studies of reduction in like feeling angry about things or as worried about things.
We talked about the mind, the brain body connection, right?
Yes.
So okay.
Yeah. So, because, maybe like this is a silly analogy, but if you're trying to do something and like improve your confidence, you stand in front of a mirror with your hands on your hips and you're
shout.
like, I can do this, and it's kind of the same. That may or may not work. May or may not work for some people. But, if you can't make the emotion, you're going to feel it's associated. If you can't make that face, you're going to feel that emotion a little bit less. So interesting study there.
Very interesting. I want to get your take on something.
Please.
So when we talk about longevity, to me, you can break down actions concerning your longevity into two buckets. There are preventative things you can do that are going to reduce the likelihood that you're going to develop chronic disease and reduce the rate of aging. So those are like your three pillars. Diet, sleep, exercise. We all know what those are. If you dial those in, the chances that you're going to live a longer life and those years are going to be more healthy increase exponentially.
Right.
Do you agree?
I completely.
Then you have things that you could maintain. It's like, I'm trying to think of maintain or like preserve your youth. And that I would imagine majority of them are procedures. And I'm wondering, like, would you say Botox is a preservative in a sense of helping you to if not the appearance of, if not just the appearance of, because we've also talked about instances where Botox can be used to treat chronic conditions like TMJ.
So I'd say that it can slow down. It's not going to slow down the inevitable, which is, the face from an aging process. It's going to slow, it's going to happen, but it can slow down the rate at which it does happen. So, with being able to prevent fine lines and wrinkles, that's what we see on older faces, not younger faces. You look at, a 18-year-old face and it's just, you don't have a bunch of lines all over it. But then if you're looking at the 80-year-old, yes, there's a lot of laugh lines and there's a lot of stories behind all of those. And that's beautiful too. But you can slow down the rate at which you do age if you are preventing, say, continual, movement of the muscle that's creating the line. So yes, in that way, it can help slow that down. Also, there are other procedures like microneedling that or PRP that can just and we'll talk about that. Those kinds of things that just kind of help to keep that, I guess, metabolism of your collagen and skin health going a little bit longer. Again, everything just slows down. Lasers too. It just slows down the rate at which we age on the face. So yeah, it's a beautiful blend of, hey, we're not going to change the fact that these processes are going to happen in your
natural.
face.
It's going to happen.
It's going to happen.
Until we get to the point where we find the fountain of youth and we're all going to live forever, or we download ourselves into the cloud. We're going to age.
I always tell my patients, I'm like, I don't want you to look like you're 20, like if you're 50. No one wants to do that. We all want to look our age, but I always tell people, hey, instead of that,
best version of our age.
Yes, best in class, not a different class, just best in class.
I like that.
Yeah.
Because to me, it actually wasn't a clear-cut answer. I was thinking about if Botox fit into either of those categories, and initially I was like, this seems like a preservative method, but my guest before you, Dr. Megan Peachinen, she's a facial pain and headache specialist, neurologist, and she uses Botox to treat trigeminal neuralgia, and that's a facial pain disorder, and it can be chronic. Like these people are suffering from this facial pain for like years until it's the needle and them. But so in that instance, it may lean more to the spectrum of preventative because you're using it to prevent a chronic condition. You could dive more into the weeds of like what's the root cause of the trigeminal neuralgia, and that's a totally different conversation.
Yeah, what's the root cause? Sorry, we're gonna get political there. Yeah, but I mean, too, with migraines, I used to actually land in the ER like twice a year with migraines. I had really severe migraines growing up. So in my early 20s, I had them, and then I started getting neurotoxins at the age of 25, and that's ironically when my migraine stopped. So, I mean, I do think that there are applications for, such things in that kind of preventative. Hey, if we can keep this girl out of the ER twice a year, that's great. So it's a beautiful blend between, hey, some of this is just what we want to lean into. Some of this is actually having a nice medical preventative relief.
Absolutely. And then you mentioned PRP.
Yes.
Can you explain to the audience what PRP is?
PRP is platelet-rich plasma. So it's actually your own blood product taken, via an IV, and then spun down in a centrifuge. So all of the good stuff, the platelet-rich plasma, which typically is like a yellow hue, kind of floats on top, and then the red blood cells that are heavier by gravity because it's expedited by the centrifuge fall to the bottom. And we know that the PRP, the plasma that's sitting on top, is really rich in growth factors and a lot of other goodies per se that help to stimulate the body to do the things that we want, maybe in an aesthetic like an aesthetic procedure. So it's going to help to upregulate how much collagen and elastin we have in our skin health and maintain that integrity and boost that a little bit more.
So this is more so, again, it's an injectable, right? You would sort of like it is and it isn't.
Yeah, it is and it isn't. You can use it in addition to say something like microneedling to enhance the results and what happens there. You can use it as an injectable if, we have like platelet-rich fibrinogen, so it's a spin-off of PRP that can be used to treat like darkness under the eyes. So a lot of really cool applications that can just help to heal an area, like patients with acne patients with microneedling and the scarring that those acne patients might have. There are a lot of studies on microneedling with the addition of PRP and how much even like the benefits are even more.
The acne just like dissipates, it reduces.
Yeah, and the post-inflammatory hyperpigmentation, like the dark spots that can be present after an acne mark, say, goes away.
Those go away.
Yeah, it can really help. So microneedling alone helps, but there's even more evidence that microneedling with PRP is even more healing.
When you spin it down and you're injecting the platelet-rich plasma into that area, are you're introducing these good things, these goodies into your body? Are the goodies themselves healing your body, or are they signaling to your body to heal that?
They are signaling to your body.
They're signaling to your body.
Yes. So, as medications kind of work in your body, they're, turning things off, turning something on, upregulating, downregulating things. That is what PRP is doing.
I see. Okay.
Yeah. So, we have these messengers that, run back and forth and say, hey, over here, we want to upregulate how much we're producing of this. And PRP is the thing that does help to control that. Which you know something about regenerative medicine, a thing or two, don't you?
Maybe.
Yeah, maybe.
I did 2 years working for a cell therapy lab. And we did, our main project was I wrote a blog post about this. It was the mRNA CAR T therapy project as well. Unfortunately, the lab did not stand the test of time. My boss got a really good opportunity in another state, but so hats off to him. But for the time that I was there, I learned a lot. I learned so much, and because I had to read all these papers.
Yeah,
and that's part of the again, another thing that just aided to where I'm at today with what I have decided to do with my life. Was that time in that lab is just getting exposed to this world of regenerative medicine. I can't. So a thought just occurred to me. You're spitting down a patient's own blood. What happens if that patient's blood's for lack of a better term, bad?
So, patient selection, that's kind of where you really have to talk to patients. People who eat unhealthy diets have never done a day of exercise in their life. So, it's hard to have an age cutoff because there are some really healthy 80-year-olds who are running ultra marathons. And then you have the 20-year-old who's just eating donuts all day,
Yeah.
So
spit down his blood and there's powdered sugar in the blood.
No,
and just you're whoa, dude.
I'm not even kidding. You can actually tell a difference. We've taken patients' blood before and I'm like, it should be that nice, beautiful liquid gold yellow hue.
Yeah.
Some people are gray.
Ew.
And I'm like, Oh no. Oh no.
It's like Shannon, do I need PRP? It's like, you need insulin. That's what you need.
Yeah,
you need
yeah. I'm like, you need Jesus. No.
Jesus will reverse your type 2 diabetes.
We love our patients, and they should, yeah. Lifestyle
My treatment
management.
advice is for you to seek religion.
Yes. Yeah, no. Just some diet and exercise, it's shop around the perimeters of the grocery store. So, yeah, it's really unique because, picking patients who are going to be good candidates for regenerative medicine treatments are, it's interesting. Do you pick the smoker? No.
Probably not.
No,
I
exactly.
wouldn't. And I'm not even a doctor. Like, it just logic to me just sounds like you probably shouldn't do that.
Yeah, exactly. So, I mean, like, I love the fact of like being a PA and kind of thinking on a broader term. I just had a patient yesterday who was in for cool sculpting, but she has an autoimmune condition. So if she's not going to break down fat cells appropriately and she's not going to mount the inflammatory response that we want her to because she's on an immunosuppressive medication, I need to tell her before she spends, a ton of money on a procedure that you could have less than ideal results. Ideally, we'd have you off of this medication. So I just love being able to think about, medicine in a broader way and how it ties into something that's aesthetic.
No, and I think that's a great point to make because, again, let's just tie it back to our earlier discussion this is why it's important to be educated about the education of different medical professionals because you have the training and the diagnostic ability and the nuance to understand and set and create a treatment plan for your patients. Whereas maybe your estheticians, like, because you guys do like a journal club, they're probably more learned than like your average esthetician, but still there's that difference in training. That's all I'm trying to point out is that difference in training.
Yeah. And I mean, even too, having worked in plastic surgery, like just recognition of different disease processes. Like again, someone came to me for another body sculpting procedure and I'm like, actually, I think that you have lymphedema. And I knew that because I worked with this, the doctor who we were doing very specialized surgeries for lymphedema. So, being able to recognize things, I love being able to do that for patients and knowing someone's background before you do go to see them, it's really interesting. I mean, I'm just saying, I've been to that doctor who you tried to get into it. You'd like, oh, first available. Well, you might not want the first available person. They might be available for a reason.
Yeah.
No hate to people who don't have long wait lists, but I just think that that's an interesting point to tie back.
No, absolutely, and it's just nuanced treatment plans because someone might need just Botox, like you just described different patient stories where they say they want one thing, but then it's like you get the background, you're like, you need something else.
Yeah, and honestly, I don't put that on patients to come in like when someone comes in with for their annual checkup, they don't come in and say, I have high blood pressure. What are we going to do? That's up for you to tease out. You know? So I think that it's just interesting to like.
It's like you can give them options.
Exactly.
Right.
And understanding those different sectors of medicine.
Absolutely. So, I want to get your take on another thing. So before this podcast, because I was brainstorming with my mentor, and he sent me a very interesting meme. I'll pull it out. So.
Oh gosh.
Yeah. So for people who are just listening to the podcast, I'm just going to describe the meme. So on one side we have a picture of Rue McClanahan in 1985, 50 years old. And on the other side we have a picture of Sofia Vergara in the year of our Lord 2025, and also at 50 years old. So, looking at this picture, despite both these women being the same age, they look remarkably different. So I imagine that a Sofia Vergara or like I'd say another celebrity like Jennifer Lopez, right? They're probably coming to you or a practice like yours to help them achieve this look. Would you agree?
I agree with that. First and foremost, Sophia's obviously wearing much less clothes. So maybe that's a huge change. But yeah, I mean, celebrities, oh my goodness. Like when people come in and they compare themselves and say, hey, I want to look like this celebrity, I'm like, You have no idea. They actually probably have someone privately coming to their home and doing these procedures, lasers, microneedling, Botox, fillers, and they have access to so many different things. When your only job is to look good on screen, you invest in yourself and your looks. And for that would rack up a huge bill. And patients who come in, and want to spend maybe like $300 on something, you're not going to have the same kind of result. So, I mean, it's changed from the 80s to, now what expectations of 50 looks like. Of course, there's a lot more that we know now, and aesthetic medicine has come leaps and miles. I mean, Botox was only invented in the 80s.
Botox was invented in the 80s. I didn't know it was that old.
Yeah.
In the grand scheme of things, it's recent, but like 80s, okay.
Yeah.
So that was around her time.
Yeah. I mean, I'm just saying shout out to the Skin Center because they were one of the pioneers of injecting.
You were telling me about this earlier off camera,
Yeah. So it's been around for a while. It hasn't been around that long. So, I mean, you see this slower descent into that aging as we can implement these things. So, yeah. Do we have new standards? Absolutely. Do we probably have the same budgets? Maybe. Depending on the person. Yeah.
Nowadays, and there's $300 can get you a lot, but when your job is to look good and you have the money to invest, there's a lot you can do. So I think that's a great point that you brought up. So I'll bring up another picture. So we have here one of the greats, Sophia.
Yes.
We got Salma Hayek here on the cover of Sports Illustrated Swimsuit Edition 2025.
Yes.
But like, listen, all jokes aside, I actually think this is like really impressive. That she's 59 years old, and she looks. I can understand if you would mistake she's in her like early 30s, early or like late 30s, like just for me.
Yeah.
Just like looking at her. So, I imagine we talk about different ways to approach longevity. I imagine she's doing both preventative and preservative approaches to achieving that look.
Yeah.
When you look at this picture, Shannon, like, so you say, what probably comes to mind that she could be doing?
A breast augmentation. Sorry.
Very,
I have
very
to call
obvious.
it out. But I mean, yeah, as far as like, it's anything from body sculpting to body tightening. People are getting plastic surgery at younger ages now. Like, we used to think of facelifts as maybe something that you do in your 50s and 60s, but now, budget's allowing for people, they might get them sooner.
It's also exposure, I think, too, don't you think? Like, the fact that I think we talked about this off camera, but I was asking you, like, when's like a good age? Like, do you start Botox? And I think you mentioned like a twin study of some kind.
Yeah. Oh, yeah. So the twin study, there was a twin study performed over 2 women, obviously the exact same age, and over a period of 13 years, they were followed. The one was getting Botox 3 times a year. The other one maybe sporadically got 1 or 2 treatments over the span of those 13 years. And you could see like the skin health, like the collagen was more maintained in the person who wasn't moving as much. Over time, yes, it can help slow down that rate of aging.
How old were the 2 women in the study?
I think that the time that they ended, it was age 40. So they implemented it younger. So for the
Did
past...
they start in their 20s?
Yeah.
Wow.
Yeah. And I mean, you'd be shocked. I have treated patients as young as like 19 and 20.
Okay.
For Botox. A lot of people will come in and they say, and I mean, that's where we start getting into like baby Botox and just like small levels of it. Then when people complain that it's not lasting as long as the FDA would claim, then it's like, well, yeah, you're getting a much lesser dosage. So that's what we can expect. Yeah. But yeah, a lot of people are getting Botox younger and younger. So, we're exposing ourselves and, when I was growing up, I thought that Botox was something that like a grandma did.
That was my impression too.
Right.
But that's not the case anymore.
No. And I would be really interested if everyone honestly answered if they were having Botox, and their husbands or boyfriends weren't around, how many people would be raising their hands. There is stigma attached to it. So, it's something that everyone wants the look of. No one wants to admit that they're doing it or getting it done. A lot of celebrities will say, oh, it's just olive oil. Oh, it's just this. Oh, it's just my meditation.
So okay, it's really funny you say that. So so before I dive into, I have like quotes from some of Salma Hayek's interviews that I think what you just said, you're gonna laugh. But real quick on the exposure thing, yeah, just to tie it back, because now I think it's more acceptable nowadays to do aesthetic procedures, like especially like for young women, like they're looking at like maybe their favorite celebrities, like Salma Hayek, right, and they're getting their certain things done, and they're like, okay, like so it's like exposure and the knowledge at a younger age then leads to taking these measures earlier, and then you're seeing a slowing down of the aging process on a population level in that sense. I don't know. Would you agree?
Yeah, I agree with that.
All right.
But what does Selma have to say?
Yeah. So when looking at her interview excerpts, because you just said that, some may say, they might not come out and say it, but they'll say like, oh, like I meditate, or I drink a lot of olive oil or something. I don't know. So when looking at her interview for her Sports Illustrated shoot, I had to kind of go through a couple of sources. Basically, it's like, what's her secret to looking like that? Here's what she said. She doesn't care how she looks. Which, yeah, that's okay. You have self-esteem. That's great. That's awesome. She doesn't wash her face in the morning. I don't know if I believe that.
So not true.
Yeah, okay. She's like, I never wash my face in the morning. I think it's bad for my skin. I just moisturize. I really only wash my face at night.
Okay.
She meditates pretty much every day. She's like, I invented my own style of it, so it's not boring. I can do it till they come and drag me out of my room. I can go for 3 hours. I just access energy, and I'm like tripping for hours. And I'm like, I wonder if that's meditation or something else.
Okay, yeah. Sorry, Salma.
She listens to her skin, which that makes sense. But what was interesting is she pointed out like a couple of different products she uses. So there was one called the Beauty Sandwich SSO1 Secret Sauce. And there was there's one called the Joanna Vargas Serum and the Le Mer. So like I wonder if like maybe she legitimately uses these, but also maybe that's like a product
sponsored.
Yeah, exactly. So I was like, so that article didn't really tell me much, because I was like, for my logic, I'm like, you have to be doing some kind of like hand
that on over here.
Yeah, I'm like you
dear
have to,
audience.
Yeah, you have to be doing
that is easily lip filler. She's likely had a brow lift. No 58-year-old, and that's not just a blepharoplasty. She's probably had a blepharoplasty and a brow lift. She's definitely had like a lower facelift / neck lift, and and at this point in time too, she's definitely had a decent amount of other facial fillers to support, because we think of it again as that disease process. You can see the bony reabsorption that happens, and that is not happening.
Right.
Like there are just hallmark signs that happen by the time that you are 59.
59, yeah.
And this is not just meditation. You cannot meditate osteoporosis away. You just simply cannot. So, like she's definitely had a tummy tuck, plus or minus liposuction.
Okay, see, this is why I have you on. This is like you could just like point. I was like, she did this, she did that. Like
it's so bad for me when I'm out in public. I'm like, bam, 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 bam. And you just see it, or you see good ones.
You're just like, what?
Yeah, and I mean, honestly, too, like that's the best part about like a good plastic surgeon and a good injector.
They can point it out.
Undetectable, and
it's undetectable unless you have an expert eye.
Yes, and a really good artist lets the clues of aging sit there.
Well, so to an uninformed person like me, I don't know. Like I'm looking at her, I'm like, yeah, I think she's like in her early 30s. Like I'm shocked that she's 59, but then you're pointing all this out. I'm like, wait, I can see what you're saying.
This is easily, I'd say that this is easily like a $200,000 body, easily.
$200,000, Jesus.
Yes, yeah. I mean, like body procedures
she has
like
more
that.
Than that. She has to have more than that with all the roles and the money. But case in point, money you have to invest in yourself, and do all these things.
And I mean, on a chronic low-lying level, she's probably getting some sort of laser or microneedling, and Botox every 3 months, and that's going to run you probably for how much she's getting is probably going to cost her like $700-800. But yes, of course, these companies will, say, oh yeah, and just for this little bit of partnership or sponsorship, go ahead and name drop XYZ. And that's the day and age that we live in. And we also live in one where, perhaps in, I don't want to get too down this rabbit hole, but you know, the expectation for women to look young but say that they're doing nothing, and it's this annoying thing, and I understand it.
Yeah.
And I respect it. And, you know, we don't all want to say, oh, yeah, I just look this way because of X, Y, Z. No, we have a natural amount of beauty per se, but that's the point of aesthetic procedures is to highlight that and complement it, not to.
Just to lightly touch on that as well, because like I'm looking at her interviews and she's like, oh, like I work out minimally. Like there was one times where she says, I only work out 4 times a year. I'm like, that's not true. You can't, like that's just not true. She just has really good genetics, which, hey, like that probably does play a part.
Yes, absolutely. Genetics are huge in aging.
She does say like high-tech skin tightening machines. I'm like, okay, that's honest. That's honest.
There's some honesty.
Okay. Holistic lifestyle. And I'm like, probably, but where I'm going with that one actually, and wanted to talk to you about, we touched on this, is just the gap between what the wealthy have access to versus, you know, us plebeians, right? It's just like what we're able to afford.
Yeah.
It being $300 to invest in yourself and what that gives you versus $200,000 she's probably spent, if not more, into her looks over the course of several years.
Right. I mean, literally one of my coworkers was offered a position to a celebrity because celebrities are not seen coming and going.
Yeah.
From med spas or plastic surgery offices necessarily.
I mean, that's probably by design. Like they don't want to be seen to do it. Because it's the part of the illusion.
Yes, it's all part of the illusion, and they are paid to keep that up.
And for me, it's like, as long as you're honest about that, but then we just touched on unrealistic beauty standards, and it's just like, have you just come out and say this?
Right.
That probably would alleviate some of that anxiety to look a certain way, because it's like, all right, like this takes work and this takes things you need to do, like, but that's fine. That's realistic.
Right. And I mean, the same ties into health. You know, if someone was just like, oh no, I'm just like born with like amazing blood pressure, but they're over here taking like a bajillion medications, I don't know. It's just tying it back into medicine. Not that people are going to lie about that necessarily, because no one's walking around sporting their blood pressure, but it's this very visible portion of your health. And people don't want to admit. And I think it's sometimes maybe embarrassing too. Hey, I'm willing to spend X amount of money on myself in this way.
Yeah.
So
then we dive into like the vanity thing, like, oh, you want to like spend that much money in, which it's a human emotion.
Yeah.
If we weren't somewhat like, there's the difference between being a narcissist versus having narcissistic traits and tendencies. We all have narcissistic traits and tendencies. If we didn't, we would be like, we'd be serving others to the point that it would be unhealthy for ourselves.
Right, exactly. And I mean, I just operate, you have to fill your own cup before you can fill other people's.
Absolutely.
And, you know, people can decipher what that comfort level is for themselves. But I do think that it's a real problem in society, especially right now, you know, with seeing your faces with filters on them and coming up with unrealistic expectations and mixing that into aesthetic procedures, and then seeing, well, so-and-so got this with olive oil or, you know, meditation. What can you do, you know, with me? I
think it begs the question, though, that given that we know that us achieving such a look is possible, whether it's financially possible, that's a different conversation, but it's possible. I think it begs the question, like, is that what we should expect 50-year-olds to look like now? Like, is that the new 50?
I don't want to put that on everyone.
Yeah, of course. You know? No. But like, we talk about unrealistic beauty standards and like how this feeds into all that. It's like, is that now the expectation?
The aesthetic industry is expected to grow by another 5 billion in the next couple of years here, which is insane.
That is insane.
So I do think that people are going to continue feeding into this new normal. I think that we're kind of there. Especially with regenerative medicine. Regenerative medicine is this huge wave in aesthetic right now because, you know, people are swinging away from, hey, I don't really know what that substance is. Can I use less of that and more of me?
Right.
And try to replace myself with myself.
More PRP, less Botox, right?
Like, exactly. And I love that kind of treatment plan, like keeping it as respectful to people's natural anatomy as possible and honoring what they're born with. I love that.
Me too.
And I think too, if I can just explain the aging process and how some of these procedures are designed to slow that down, but you have to have the right patient expectation for that. And just as a society in general, I think that it's just becoming more and more accessible to do those kinds of things. So yeah, I do think that we're heading there.
So that being said, Salma Hayek has millions of dollars at her disposal to achieve these things. What are some tips for people who don't have millions of dollars at their disposal? Like, is there anything we can do to get as close to the best version of ourselves looking as we can? What do you think?
So I think that it's about small, sooner, earlier interventions rather than waiting until you're like 60 and you then want to look like her. And it's like, well, then that's going to take a lot of upward momentum to make something like that happen in a huge budget. But, for the younger patients who are, know that they want to head on this trajectory and like maintain their appearances, and looking as youthful as possible. Yes, things like retinol. I mean, obviously, like SPF. Prevention. An ounce of prevention is worth so much more down the road.
An ounce of prevention is worth a pound of cure or something like that.
Yes, yeah, exactly. So, I mean, doing preventative measures first. If we slow down that level of UV radiation damage, yes, people in Pittsburgh, I know the sun is not out, but you should still do it. In fact, there's a lot of study about how blue light, which is available with screens, with our phones.
There's no shortage of blue light in this.
Exactly. So, I mean, like even that, if you're wearing like an SPF, a mineral-based SPF, that can block from it. But, between doing that, retinol, lower, like not aggressive treatment plans, but microneedling spaced sporadically is a beautiful procedure. And like using PRP, doing those kinds of things, implementing smaller amounts of Botox just to maintain on a lower basis prevents this big wave where later on you really need to dive into
and that actually blurs the line between the preventative versus the preservative line actually is like if you actually use these in conjunction, because you dial the thing. I think it's like you also have to dial the sleep, dial the diet, dial the exercise in, and then that's only going to augment the preservative treatments that you come to you for. Right?
Yeah, and I mean there are some interesting studies about like sunburns earlier in age. So, a lot of dermatologists will, if you had like so many sunburns, when you're younger, your body recovers better because you are just closer to that state of being able to heal. When like young kids break their arms, it just heals so much faster than say the adult who's like got diabetes and all these other, because you have this chaos, this state of chaos that's kind of ensues in the body. At one point in time, we're all hopefully, and I'm not we're all, but we have a healthier state of our body. And then as we go on the aging process, things break down, just like the tires on your car break down and you need to go ahead and replace those. Everything has a warranty on it, right? And over time, it's gonna slow down. But if we are able to, if you get your oil changed consistently, you're gonna have less wear and tear happen to your car. And if you just do those small little preventative measures, it's gonna be a lot better. But to bring it back to the sunburn thing, when you're younger, you recover from that so much more. But then as you get older, you're more likely to develop these skin cancers because your defenses aren't nearly as like present and active.
Actually, in a lot of ways, youth can cover up the damages.
Yes.
And like that's both a good and a bad thing because you gotta make sure you check under the hood every now and then.
Right.
And you're staying on top of things, which I get it can be hard because job stress, kids. I know everyone has a different situation, but still, if you do what you can.
Yeah, health is everything, though.
Health is wealth.
Yeah. And the moment that your health slips, everything else kind of falls out of balance, and you have to focus on you. So it's better to, do it first before you're literally forced to. So
absolutely, no. I think that's a great place to end off on. Is you don't have to have $200,000. I mean, $200,000 to $1 million helps. Don't get me wrong.
Yeah.
But you don't need to have absorbent amounts of money to look your best and be your healthiest self. Probably just takes a bit of work, a little checking under the hood every now and then.
Yeah.
You're great, right? And then you do the best you can. Until you have $200,000, and then maybe you can come to Shannon and you'd be like, "Hey, Shannon, so what's that? Special Botox?"
That's a lifelong budget. We'll put you on the lifelong plan there. Microneedling all the time. Yeah. But yeah, I mean, I think that it's a lot more accessible than people maybe want to give it credit. You don't have to do things constantly all the time. It's only to whatever end you feel comfortable. And, I'm happy to talk to people about their budgets too and come up with something that fits within that. If that is just a retinol or if it is just a twice-a-year procedure. But if your goal is to do that and you want to maintain that general skin health, that is attainable. Just as much as it is to maintain your general health. If you're, talking to a physician assistant or your doctor about, hey, this is my goal. I want to always keep my lipids within a healthy balance. They're going to say, hey, you're going to definitely have exercise and this kind of diet. So it's holistic. It's all encompassing, and it is very attainable, assuming that there's just a little bit of effort on patient end and provider end too.
Of course, because it's a teamwork, as it's a common theme in this conversation is it takes a team to accomplish these goals. So if everyone was working together, we can accomplish that.
Yeah.
If there was like one last piece of advice or something that you would want to say to the people watching this podcast, what would you want to say to them?
I mean, genuinely, if you made it this far and you're watching all of this, thank you so much for tuning in. I really think that, being an advocate for your own health, communicating your needs, being in touch with your body, communicating with your providers and your team is, of utmost importance. And, if you're taking care of your body, all the aesthetic stuff, kind of follows after that. So knowing your role in the order of things, and, for anyone who's considering kind of the medical model too, there are so many different avenues that you can go, and it's a really special journey to kind of go down. And obviously people's whys to be in it too. So if you're out there in the workforce, just remembering why you started and, just kind of honoring that. So it was such a pleasure being on this with you today.
Thank you so much for coming on. Where can people find you?
Oh, yeah. I love social media. So I'm on Instagram as Shannon Masterson. And then if you want to come visit me professionally, I work at South Point location for the Skin Center. And then if not, I'm probably in a workout class somewhere in Shady Side or the Strip District. So, I'd love to say howdy, or maybe Mind Fuel or Strike Studios, galleries, all the Pittsburgh things. Come on out, guys.
You guys got to come. Definitely give Shannon a follow just because, like I said, I knew you by reputation first, and her content was great. It was very informative. Actually, the thing that stuck out to me with you when considering who to invite on for this particular topic, I will say is, I saw when I did a little bit of Instagram stalking, and I saw your content, but then I saw you posted something on your story. And normally when people take flights, we're like watching a movie or we're sleeping or we're just listening to music. She's like reading papers on an airplane.
Oh, yeah.
And I'm like, okay, she's about it. Like she knows.
She's nerdy.
She's nerdy. Yeah. So I was like, all right, podcast guest.
Yeah. Thank you.
But no, thank you so much for coming on. And thank you for everyone watching. And thank you for Studio Me for the brand new spanking studio. It's been a pleasure using this space, and hope to host many more. Take care, everybody, and goodbye.